you in many more of our sessions. We shall go on to my talk on regression post-refractive surgery, when and how to intervene. Now I'm going to try to go fast. That we all know that if it's a high refractive error, a thin stroma, if you have made a mistake of using a smaller zone, and if there is high astigmatism, a patient is older in age group, dry eye status, if there is a progression of axial length, it could be that, keep that in mind. Or if there is a latent hyperopia which is unraveling and lenticular shifts, these are the causative factors. And then why? Why is all this happening? Because epithelial hyperplasia and remodeling is occurring. It occurs more if there is an inflammatory cascade, if there is a dry eye status, because there could be also inflammation, there could be altered reinnervation patterns, steeper gradients which can happen in high myopic and astigmatic correction, increases the epithelial response, stromal mechanical, biomechanical response, reduced tensile strength because of the thinner stromal bed, and forward protrusion of the posterior lamellae and the myopic shifts which occurs. That is why people say that there's a temporary role of use of an IOP lowering agent, although we know it does not stand. Regression, again, we see more in microkeratome flaps because of the meniscus configuration of these flaps, which encourage more epithelial remodeling to the planar configuration, more seen in high corrections in surface ablation. And the good news is that SMILE has lesser regression than LASIK. Now what do? You have to investigate and plan our course. So slit lamp, look at the flap edge. Is the edge looking regular, irregular? Is it more fibrosed? Is it going to be a little difficult to lift the flap? Is the flap looking centered? How is the hinge looking? Is it low? Look at the corneal thickness. Is there a pachymetric progression? Is the surface irregular? Is it regular? Is there an inferior steepening, skewing axis? Look at the floats. Is there any suspicious elevation points? Look at aberrometry without fail. Is the optic zone okay? Is the higher order aberrations more? Is the point spread function more? Do you need to enlarge the optic zone? Do you need to do something more when you're treating this patient? Look at the epithelial maps. The thickness of the epithelium will help you plan your enhancement. Please, without fail, do a biometry in all these patients. Do an ASOCT to understand the flap thickness and the uniformity of the flap. And if it is a dry eye status, please treat it before you do enhancement. Now your options are many. I'm not going to read out the option. Let me go option one after the other. Flap lift, I would prefer to do it only less than 3 years of, and that too, that I would keep as an outer limit, and I would try to be very careful with I lift the flap, make it smooth so that you do not disrupt the epithelium surrounding, so that you do not have an epithelial ingrowth. Try to aim for a centered flap within safety parameters. Avoid lifting thin flaps, buttonhole flaps, irregular flaps, even if it is less than 3 years. And if beyond 3 years you find you are not you can't do a surface ablation for any reason, it's better to debride the flap a little beyond the flap margin all around and then lift the flap. Now if you're going to lift the original flap, there may be a need. What has happened that the primary flap is decentered. You could think of taking a deeper cut if the thickness really allows. Now, these are all more in the microkeratome flaps. Yes, sometimes in a femto flap also you could do. There is some people who do mini flaps if the primary flap is very thick, but there could be flap fragmentation, best not to do. Surface ablation is a major boon for primary enhancements or even for complicated cases, but I would like to add a mitomycin in every case because it definitely is needed to address the haze which can occur, and if it is a borderline topography, I wouldn't mind combining it with low fluence cross-linking. I'm sure Sri Ganesh would agree on that. And of course, in thinner flaps, you should expect microstriae when you are ablating over a thinner flap. Be prepared that there could be an delayed epithelial healing in some of these eyes, so please plan your protocol accordingly. If it is a SMILE, it depends whether you want to stay flapless, then you could go ahead and do a primary SMILE above or below the primary SMILE. Dr. Sri Ganesh has experience on that. I don't. You could do a PRK. You could do a circle software, and again there is this option of doing a thin flap LASIK if the initial cap is quite thick. the basic important thing we need to know is to do a thin flap LASIK, your initial flap has to be very thick and it should not impinge on the original interface. That has to be kept in mind. I already told you. When you do a smile can be converted to LASIK, and this can be done if you use a circle software. There are different approaches. I'm not going to go into A, B, C, D, but the most sensible approach is to do a D approach, where you create a lamellar hinge and then the junction cut and the side cut, and you lift the flap. As you can see, you have created a ring around it, and then all you have to do, you have converted the smile cap into the flap, and you go ahead and lift the flap as it is being lifted here, and then you go ahead and do the excimer laser. So what we need to understand is that these are the different options which we have if you want to do a regression treatment enhancement post-smile procedure. Commonly we would do a PRK, we could do a circle software, otherwise smile over the cap or underneath are the different options. Phakic IOLs would rarely be needed for large residual errors. It should have been a mistaken entry. Otherwise, I don't think we would need to do a phakic IOL at all. As far as the complications is concerned, let's remember all the primary complications can occur. You should anticipate epithelial ingrowth. You should anticipate haze. You should anticipate ectasia. You should anticipate DLK, and rarer occurrence of infection and increased dry eye status has to be countered. But let's conclude saying that investigation, regressions can be definitely well managed. Kumar, can you connect your slides, please?
Excellent presentation, ma'am. I'd like to ask a question to Dr. Somshila and Dr. Dhami, sir. At what point of time would you take the decision for retreatment? The period after the primary surgery has been done.
So, as you mentioned that if it is obviously an erroneous entering the...
No, suppose there is no error, you have treated perfectly and you are seeing regression. So at what point of time would you diagnose it? At what point of time would you take the decision of treatment?
So if it's LASIK, pretty much by the end of 1 week, I know that there is,
So how would you differentiate between undercorrection and regression?
No, she's asking a very valid question. What she's asking is, when are you going to do enhancement? You know there is regression has happened. What
so
did
we
you
need
say?
to differentiate for the
so
benefit of the audience. We need to have, these are basic questions I understand, but I just wanted some more clarity.
I'll just try to answer that very briefly.
Yeah.
So when we're using the term, what we mean is, let's make it broader and say residual refractive error, or a refractive error after the refractive surgical procedure.
Yes.
So it depends on the duration, depends on the cause. As we mentioned, incorrect entry can happen very rare. So we do it right away. There's no point waiting. Unless it's PRK, then you need to wait. But then if it is if it's regression, as in it comes in later, it comes in at 6 months, or the patient comes back to you at the end of 1 year, and you see that it's stable. So you might have a couple of visits for the patient to make sure it's stable. You assess and see that it is not sort of an ectasia, and if it's epithelial thickness, that still needs to be corrected. So to answer that, we can't have a short answer. Depends on when has the refractive error reappeared, and what is the cause of it. So those two, and it would have to be decided case to case. Also, so many factors, like there could be an accommodation by the patient. You have to remove those reasons of, those issues, exactly.
Yeah, and you would want the topography and the refraction to be totally stabilized, and definitely the minimum wait should be 3 months post-refractive surgery procedure before you consider taking up. And the options, of course, whether you're going to do a PRK or a flap lift comes based on all that I said.
Yes. So wanted to say something.
No, we should do Kumar, because I think we have to hand over the hall. Kumar has come.